Professor Rummery will present her research on long-term care policies and gender equality. But this time we're privileged to we're going to have commentary from Alison Johnston, MSP, who is the Green spokesperson on rural affairs, environment, culture, education, health and sport, co-convener of the cross-party group on children and young people and animal welfare, and deputy convener of the Scottish Parliament's Devolution Further Powers Committee. I think all of those different things will have a different kind of perspective on what we're, not different, but have a perspective on what we're talking about. And then we're really privileged to have Heather Fiskin, who I know from other connections. She's the project manager for independent living in Scotland. Heather has played a significant role in making the strategic interventions necessary to support disabled people have their voices heard by decision makers. So we have two, again, very interesting speakers who will provide a commentary after we've heard from Professor Rummery. So over to you.
Thank you. Right. Thank you to those who've stayed, and welcome to new members, because I know some people have come in specifically to hear this bit. I'm going to talk a little bit about long-term care, and the Economic and Social Research Council were quite surprised at this element of the project, because care in terms of achieving gender equality through childcare is quite well known universally and across international contexts. But the idea that you might want to achieve gender equality through long-term care and disability care and support is slightly more contentious and slightly more kind of challenging. And I had to make the case to them, and I'll make it to you, but hopefully I'm preaching more to the choir here than I was to the Funding Council. It's often neglected from a gender equality perspective, but it does matter in several ways. Firstly, those of you who were here this morning, remember I talked about the importance of looking at the ideology and values behind certain policy interventions. And that's applicable in childcare, but also in long-term care. And actually in any policy area. If you look at what it is they're trying to achieve, you have to look at what the values are, what the aims and the ideology behind what it is they're trying to achieve, because that will drive how they try and achieve it, and the importance that they give to it over other, sometimes conflicting policy objectives. If a country presumes, as I would say that we do in the UK and in Scotland, that family should have the primary responsibility for providing long-term care, then we know, we don't need to be told, but there is lots and lots of evidence on this, that this burden is placed disproportionately on women. And that is an ideologically value-based assumption. That is not a natural assumption, that is built in socially, culturally, and politically to the policy. Most intra-generational care, in other words, where we're caring for children or we're caring for parents, is done by women, and most intimate personal care is done by women, and most of the care that keeps people out of work and is high impact and has an impact on people's earning abilities and their poverty and their risk of poverty, and the kind of thing that's very pressurized, that is done disproportionately by women. That is not to say that men don't care, and I'm going to talk a little bit about the kind of gendered expectations around that. But in the UK and in Scotland, mothers and daughters fall into these gendered expectations, and this is at great terms of their labour, at great cost of their labour market participation, their risk of poverty and health, also their own individual lack of independence and control over resources and control over their lives. And that is really important for gender equality, is giving women control over their resources and control over choice over what bits of things that they do. And very often what happens within the UK and within marketised systems is that carers, particularly family carers, are forced to provide much higher levels of intimate personal care than they would like to, because there are no other quality alternatives, not because they necessarily would want to. And that is a situation that disempowers both people providing the care, but also the people getting the care. That is not a good situation for anybody to be in. And it is the kind of default, if you presume that it's the family's responsibility to provide that care, that those patterns will be fallen into. It also places, and the research shows us this, lots of strain on kinship ties and lots of strain on people being able to be spouses, mothers, daughters, family, the way that they want to be, and live their lives the way they want to do. So you see a lot of marriage breakdown, you see a lot of mental health issues experienced on both sides by people receiving and giving care. In contrast, if you look at the Nordic states, where the expectation is that it is the state who provides care, and in fact, the state would be mortified if the family did step in and provide care because it would feel that it had somehow abrogated on its responsibilities, then you see that burden removed from the family, and you will see in relationship to that, there is very little or no gendered impact or cost to providing the care. Women, therefore, then tend to be less disadvantaged in the labour market and less at risk of poverty and health. They have greater control over their own resources and therefore play much more of a role in public life. You don't need a Women 50-50 campaign in Sweden and Norway and Denmark. They're already there. You might want to have women against gender-based violence because that's still endemic in those societies. But in terms of getting women into public life, it's already there. The structures have already been there since the foundations of the welfare state to support it. So that's less of an issue. And almost all of the countries who have better gender equality indices than we do in the UK and Scotland have much more extensive public and state provision of long-term care than we do in the UK. And the second reason why it matters in terms of gender equality is that on the other side, we do know that when care is provided by paid carers, as it is within the Norwegian and Nordic system, these tend to be disproportionately, but not exclusively, jobs done by women. And if that job is considered to be low-skilled, it will attract low pay, as it does within the UK, and therefore attract it attracts the low value given to care precisely because care is gendered, because care is seen as a woman's job. And it's, for example, you just have to look at the rates of pay given through local authorities to refuse collectors as opposed to domiciliary care assistants. I looked this up, £6.33 on average per hour to carers, £8.74 to refuse collectors. Again, do we value our bins more than we value our older people? I'd like to say not. I would really like to say as a society not. But and that's within local authorities. That's within state-based employers. Okay, so it's not even the market. It's actually people that we vote for are deciding on these pay rates, and they think it's perfectly acceptable to pay refuse collectors more because that kind of job is valued more because it's a man's job, and we can argue about that, but that's not what I've got 30 minutes here to do. Okay, so what I'm going to do is look at our case study countries. Trying to not depress Claire at the back there, who's heard some of this already when we talked about the kind of care and support that was available within the Nordic systems. We both got quite depressed. What is it that makes what I would call a good long-term care system? And by that I mean one that meets the needs, high-quality needs for care and support for those people who need the services, but at the same time helps towards a more gender-equal society rather than creating greater social divisions along gender lines. And it has to crucially work for both the users and the carers. This is also my criteria. It's no good putting a system in place that only achieves gender equality but leaves disabled people disenfranchised and not in control of their lives. That's not what any of us want. As I said earlier, I'm a disabled mother and a carer, and it would be doubly really quite depressing for me, so that's my own personal input into this. And then I'm going to try and draw out what the key issues that we need to consider in Scotland, rather than what could we just import or export, or what's fantastic about the Norwegian system. Look at the possibilities and the barriers that we face in Scotland, and I would say that we actually have quite a bit more leeway in terms of this window of opportunity in this particular time within Scotland than we might have over the childcare issue, for example, because of new powers coming through welfare benefits, the Smith Commission, because of an appetite for change, etc., and because of a real need to sort out long-term care generally. There is an absolute, this has not gone away, it's getting worse and worse and worse. We absolutely have to grapple this. It's a difficult thing to grapple. And then I'm going to take complete advantage of the fact that I've got your undivided attention for about 3 minutes and have a wee rant about what I think long-term care should look like in Scotland, what I think it could look like in Scotland, but probably won't. So there you go. Not that I want to depress you. Like childcare. Countries that have good long-term care systems have got the right to services embedded into their constitutions. And again, this is why, even though I knew independence wouldn't turn Scotland into a feminist paradise and it wouldn't turn it into a disability rights paradise by any means, this is why I was saying we should go for independence. It gives us the chance to write our constitution, to put the values that we as Scotland hold right in the framework of the legislation. We don't have that opportunity, but we do, and we know this from the Quebec model, have the opportunity to frame what Scotland does differently from what it does from the rest of the UK, and to identify the additional powers that we might need to do that, and to campaign for those powers if we think that's an important thing to do. So we do have more opportunities to do things than we think. We know this. The universal model, the Scandinavian comprehensive model, it provides the most comprehensive model of support. It also provides the highest levels of state involvement. Now, Maggie talked this morning about the cultural problems about getting the state involved in providing care. There is a cultural assumption, not just with childcare, but also with long-term care and family care, that it is the family's responsibility, first and foremost, within Scotland to provide care. And the state should back that up, rather than it being the state's responsibility, first and foremost. If we wanted a universal model, it's not about funding, because we would find the funding if we wanted that. We found the money for Trident, God knows why, but apparently it's important to have nuclear weapons. If you want a comprehensive long-term care system, politicians will find the funding for it. The problem is it is not valued, and that is why. But I do want to stress, because this is what politicians will always say to you, we can't possibly have a Scandinavian system because it would cost too much and all of these things. Just because the state is in charge of commissioning the services does not mean the state provides all of the services. And certainly within the Scandinavian model, there is increasing market participation, and we have people coming over to us trying to understand how you actually get a sort of multiplicity of providers involved in providing long-term care, because they know that that continued, just the state being involved in providing services is not sustainable. It's not just about money. The state being the only person responsible for providing services means that these services are quite paternalistic. These services are provided on a way in which kind of universally makes sense in terms of the providers, but it is not actually tailor-made or individualized to individual families' needs, and it's certainly not necessarily considered to be that empowering for the service users and disabled people involved. So I get a lot of kind of, within social policy, we get a lot of disability rights activists from Scandinavian countries saying, stop treating us like we are the be-all and end-all of universal welfare rights, and this is absolutely, it's not. We have a lot of segregated paternalistic provision that is not empowering, it's not within our control, it's what the state thinks is good for us, which means that access to work, to leisure facilities, to kind of being part of the community is actually more difficult within a system like that. So all of the Scandinavian countries are moving towards the same way that we're moving, in terms of towards more personalised, user-controlled services, user-designed services, co-produced services. So there's a universal movement across different models towards the services actually being in control of the person using them, rather than the state allocating resources, kind of thing. But it takes different models. And they're all using some form of what we would call self-directed support or direct payments. So even the Scandinavian universal welfare models are using individualised payments and letting users actually purchase their own care and marketising it on that basis. However, what we see, I think, in the partnership model, and this is again Germany and the Netherlands, their route towards gender equality has not been through universal state-provided, so state-driven type services. Even though they do have gender equality and they do have the right to services embedded in their constitutional frameworks, they do it very differently. They see it more as about, and it's probably more in terms with culturally and politically within the framework that we would be operating in Scotland, they see it about a partnership between lots of sectors. We do not see employers around the table in Scotland nearly as much as I would like to see, both in childcare and in long-term care, because they see it as a kind of a patchwork of different kinds of services and benefits that different sectors of the public sector, the private sector, and individuals, families and communities are responsible for putting in either funding or services or some kind of partnership arrangement. So, for example, if we look at the long-term care insurance in Germany, this is a partnership between employers, federal states, so we could do it at a Scottish level. It wouldn't be local authorities, because federal states in Germany have the same kind of level of autonomy over these kind of things as Scotland has, rather than local authorities. So it would be at national level rather than local level. And similar to the way in which we have pensions and not health insurance in this country, because we're taxation funded, but France and Germany have health insurance kinds of policies. Universal coverage for everyone, but employers are involved in designing and administrating systems. Employees are involved in paying into the systems through insurance contributions. The idea being that at some point we're all going to need long-term care, and so therefore at some point we will get back out of the system what we put into it. So like in the universal model, there is a sense of social solidarity about this. It's not a them and us. It is not this kind of disabled people, elderly people get the services, taxpayers pay for the services, which I think is still a kind of, it's embedded into the way we think about social care in this country. It's we all pay in and we all get out. And I think it's that kind of social cohesion and social solidarity that we need to move towards. And I would argue that we need to move towards that in childcare as well, even though not everybody has childcare responsibilities. But the idea that investing in childcare is something that is of the greater good and everybody benefits from it, the economy benefits from it, employers benefit from it, etc., needs to be applied to long-term care. Investing in long-term care is a good that is for everybody in society. You can sell it to the middle classes very, very easily, if you're, and this is what you need to do, as I said this morning, if you want to get voted into power, you have to sell the middle classes on whatever it is that you're trying to do, by taking it away from being asset-based welfare. In other words, you can pass your home on to your children, because you will have long-term care funded for separately, and you won't lose that kind of asset. At the moment, we are relying on assets, we're relying on people having assets, and those that don't have assets are relying on the state. And it's moving beyond that. It's moving beyond to a much more long-term solution over the life course that involves employers, employees, and those people. Similarly, the family, and this comes back to, there was a question about what do you do when you're a disabled parent, or what do you do when you have disabled children? There is a sense in the Netherlands that you can use personalised care payments for formal carers around disability and long-term care, for childcare payments, for individualised high-quality childcare payments, for the extra care that a disabled child might need. It's very kind of flexible and tailored to individual circumstances. And again, it's paid for through taxation, through employers, and through state underpinning that. And the way in which the state deals with the low-income side of things, that formal carers are paid less, etc., is to kind of boost their wages. So they tackle the supply side in that way, rather than providing structural, daycare centres, etc. They support it, and it's supported much more through the universal model in that way. But certainly Germany does have kind of minimum wage expectations, and contracts can only go to employers if they provide a certain level of benefits and a certain level of living wage for So there are lots of different levers that can be used. Like in childcare, the federal model shows that it's possible for devolved administrations to develop services which have a different value approach to the rest of the country. Now, this is long-term care. I wouldn't say we need to look at Quebec in terms of their outcomes because it's far, far worse than ours. They really, really do rely on the family, and there's very little formal provision. But in terms of policy making, it's an interesting example because it shows that you can do things within kind of devolved powers that are different to the rest of the UK, even if you don't have all of the policy levers that you think you need. There are creative ways of doing it. If you as a country or as a nation or as a devolved region really have that kind of strength of belief in your identity and your capacity to deliver, people will be willing to deliver different kinds of things. And the interesting thing about that is that not so much in long-term care, but in childcare, Quebec was a model, it was a policy laboratory for the rest of Canada. And when it was showed that, investing in early years childcare and effectively making it very, very low cost, universally available for everyone, that was then rolled out across different states in Canada, and the productivity in terms of women's labour market participation shot up, and equality on all sorts of equality things then happened. So Scotland could be a policy laboratory for the rest of the UK. Again, because we're relatively small, because we've got the capacity, because we've got the willingness. But we do need to overcome, we need to get employers around the table. There need to be the right people around the table. It's not just the state expecting more from the family or expecting more from the voluntary sector, which seems to be the partnership model that we can't afford to pay for it. We'll just get communities to give it for free. That doesn't work. We'll let charities come in. We don't want charities. We do want charities doing things and providing things, but we don't want people to have to be grateful for handouts on the basis of them fitting a certain, we need to be looking at social rights and the right to access certain services. But those services do not have to be provided by the state to be high quality. In fact, what we've seen in long-term care is that often it's not the state that provides the highest quality services. It's actually individual providers who have a specialist or niche concern. And this comes back to the disabled children idea, and it also comes back to around race, ethnic minority mixes. Classic example was one of the first ones in Birmingham to go to be tendered out for was a Meals on Wheels service that served halal food, and it hadn't occurred to Birmingham Home Care for years and years, despite the fact they had a 30 to 40% ethnic minority population, that they might not want chicken and spuds for tea kind of thing. So, individual communities are often better, and particularly I know from this things like providing specialist support for autistic children, etc. Specialised providers are actually better at doing that, and they tend to come from the third sector, and they tend to have a lot of involvement from the community themselves in in constructing and also providing the services, so peer-based support and that kind of thing. Right. It is a myth that in the Scandinavian countries it's all done by the state. All of these models involve the market, and the Scandinavian countries are increasingly involving more of the market than we do. So the inbuilt resistance to self-directed support within Scotland, and the reason why we have more people in Hampshire that are using direct payments than in the whole of Scotland, has partly been a resistance from the unions and from other areas of market involvement in the sector altogether. Similarly to, we can't have the market involved in the NHS. Actually, you can't have the market owning the NHS, but you can have the market involved in providing various bits of it, and it still be a universal, free, openly accessible service. Same in social care. There are bits of it that we know the research shows us are benefiting from having market involvement in terms of specialist providers, as long as the competition for provision is not on cost, as long as the competition is on quality, and this is where you still need strong state involvement, then you do get people competing to provide a better, more tailor-made service, and you do get better outcomes, and you do get users who hold the payment, who can exercise choice, voice, and exit and say, I don't like your service, it's rubbish, I'm going to go to the service down the road. And that is how the market works when it works properly. I can buy my better quality baked beans in Waitrose, etc., rather than my kind of mass-produced baked beans in Lidl, but everybody's got the right to bake beans. You can make choices, and you have to make sure that people have the resources to make the choices. And if I want to buy my baked beans in Lidl, then I've got a little bit of extra money that I might want some cheese with. It's that kind of thing. You know, in personal and long-term care, it's like, well, I'll pay less for this because I actually want somebody to take me to my tennis lessons, or I want somebody to do something else, or I want to tailor-make the package of care that I'm receiving, that it makes sense within my family, my individual circumstances, and I will make the decisions, not the social worker on my behalf. So you remove that paternalism from it. Okay. All of them value paid care. All of them pay their care workers far more than we do. There are far more substantive training involved, far more, pension rights, accreditation rights. And actually this mirrors, they value other sectors far more than we do as well, other traditionally low-paid, low-skilled sectors. The state has a very important role because the market doesn't do it. We know that the market values boilers more than it does children, and it values that you would not get refuse collectors in Denmark or in Germany being paid more than home carers, is what I'm saying. The state as an employer, as the commissioner of these services, has a very strong regulatory role to play. And arguably, all of these systems, and I've been researching this area for a while now, meet the needs of both users and carers better, because users obviously have more choice and control. And sometimes they have, and in all of these systems, they can pay personal carers, which it's difficult to do within our system. They can actually give the money to husband, wife, daughter, to keep it within the family. It is not, the argument against that is that it's monetarizing kinship. I don't think it is at all. It gives people the choice. It says, I will do this. I'm happy doing this for my mum. I'm happy giving her a bath. I'm happy putting her to bed. Or I'm happy doing her shopping. But I don't want to give her a bath. I want someone else to come and give her a bath. That's my mum. Trust me, I don't want to give my mum a bath, and she wouldn't want me to give her a bath. There would be all sorts of issues coming into that. But it's that element of choice and control on both sides. And that removes having to give mum a bath because no one else is going to come in and do it. If I have to give mum a bath, I'm resentful, she's resentful, I've got to make the time out of work for it, she's got to talk to me naked, and it's just, no, it's not even going there. She's staying with me at the moment doing my childcare, so I have to be very careful about what I say. But it's, and for everybody, for every family, for every relationship, that is different. What you might want a spouse to do, I'd actually rather my husband gave me a bath than a carer coming in, to be perfectly honest. He would rather I just didn't go anywhere near that. But this is the point. It's very individualised, it's very flexible, because the user is in control, and the user is in control in partnership with carers and family and kinship members. And family are considered in all of these models to be key partners in this. And that doesn't mean, you see, in the UK, when we say families are key partners, we mean you will come in and do X hours of care, because you are now no longer at risk because there's an informal carer around. So that means we as the state don't have a responsibility to provide care. And in an era of tightening budgets and higher criteria, high risk, you can only have state-funded care if you're really, really at risk. That's the way we've gone. That is not the way any of these models have gone. They start from the presumption that you have the right to care, and then they go, where's it going to come from? Not, you have the obligation to provide care and look after yourself, and we'll bring in an emergency service if everything else fails. That is what we have to change. It's not about funding. It's about the mentality and the values that underpin the system. Because we pay just as much in certain things. Other issues that I'll just go through quickly, because you know more about this kind of on the ground than I do, is thinking about funding and demand. There is an idea that we open up kind of like the floodgates to demand if we make things more universally accessible. But adequate funding is an issue in all of these, and growing demand is an issue. Everybody's got ageing populations. They're going to have to come to grips with this. Complexity is dealt with much better in the federal model and the partnership model than in the universal model, which is really a one-size-fits-all kind of thing, which is that they use leave policies. They have flexible carers policies in terms of people being able to take time off work to fill in on emergencies or just do things, work part-time and then full-time, depending on the nature of the needs of the person they're looking after. Care payments that can either go to the carer or the user or be split between both. care cooperatives where users actually organise and provide their own care, etc., and tax incentives for employers and businesses who are the invisible people who should be in this table around the table in this room talking to us. But the universal model, which is why I don't think it's a nirvana of provision, it actually got fewer supports for this. It's actually much harder within kind of Sweden to take time off to look after your mum, because the presumption is that the state home carers are going in. But I think there are some things my mum would prefer I do, and there are some things I would prefer I do for my mum, etc. And so that kind of flexibility just isn't built into the system. All of them have higher employment rates for women. I'm just going to go... These are the same kind of things that around childcare. There are certain entrenched things within the Scottish system that it would be really difficult to change. The culture, the policy, the fact that we have this division between kind of local authority provision and disability living allowance and universal versus and all that. We know all that. We have a crisis in long-term care, though, and we don't have a crisis in childcare per se. So there isn't quite the immediate issue to get this sorted, but we have to get this sorted in long-term care, or we are going to be absolutely sunk. We have new welfare powers coming, and we have a willingness, I would say, and a window of opportunity. We have policymakers listening and wanting new kinds of things. So I'm going to just spend 2 minutes ranting. Stop ring funding the NHS. Really, really, really. Just because England does it doesn't mean we have to do it. It's absolutely the most ridiculous thing we've ever done as a country. We should stop doing it. Enable funding to be moved from healthcare towards preventative services and towards social care. And this will deal with an awful lot of the long-term health inequalities that we are facing at the moment. This is a really tricky one. Take all the money for social care out of local authorities. There is no reason why we need 32 different systems of social care, 32 different systems of gaining access to them and criteria for them. It's not fair, it's not a good use of our money, our taxpayers' money, and it doesn't benefit disabled people. Combine all of the benefits that we're getting into one real, and because nothing magical happens at 65, by the way. You're dealing with a long-term chronic illness or impairment and you're disabled. Nothing magically happens at 65 that makes you an older person rather than a disabled person. All that happens is you probably will stop working. That's got nothing to do with your disability. These payments are about meeting the care costs of disability because it's acknowledged that disability has additional costs and disabled people are therefore face barriers to social inclusion. They're inadequate, but they are for the right reasons, right? So let's combine these. Let's make it needs-based, not age-based. Let's have a 3-tier universal system that happens across Scotland that is based on internationally recognised criteria, very simple to access, very simple to challenge. You either fall into one of these 3 bands and you get that amount of care funding. You can then pay it to your family, pay it back to the local authority who will provide you with services, pay it to individual providers or whatever. You will stimulate the market doing that. You also, at the same time, have to acknowledge that carers are the most exploited area of society. We have to pay them at least minimum wage. It's absolutely ridiculous that we don't, because we are relying on them. And so by this dual-pronged approach, you harness this is the partnership model extended. You harness the resources of the state, of the community, of individuals, and of the market, of employers, etc., and of providers in order to provide this. This is going to cost a fortune to set up. But once you've set it up, in the long term, it doesn't take very, very long. I've had some economics colleagues do some modelling on this, to see translation into savings, because most of the money goes into operating the system rather than directly providing care. If you make the system clearer, fairer, more accessible, you can make significant savings on that. So I've got 1 minute left. You would see significant savings and outcomes, equality outcomes in both gender inequality and disability inequality and age-related inequality. You would put control in the hands of people using the services. and it would translate some of the fantastic theoretical models we've got around disability into elderly care services, which I think is long overdue. It ain't going to happen, so you can all stop getting excited about it. One reason is that benefits rather than powers have been devolved, but we could fight for that. The real reason it won't happen is because local authorities are going to have to give up a lot of power in this for this model to work. What we need is social workers to support people, not social workers to be rationers and gatekeepers to increasingly smaller pots of money. Now, they as a social work profession would agree with that they're there to support people, but we still need fewer of them than we have, because the money that employs people to do all of the assessments, etc., needs to be centralised and then put out to services rather than that middle tier of local authorities managing it. So we would need buy-ins from the union, who won't give it to us, and we would need buy-ins from providers, employers, etc. And as I said, it comes from why we save money, why we could do this and achieve better outcomes is because from administrative savings. Administrative savings equals job losses. If any politician tells you that this is about administrative savings, that's what it means. You do need control over taxation and employment legislation in order to make this work. So some of the powers we haven't quite got yet, but we have got quite a few of them. This isn't going away. It's not going away, and we need radical solutions, so why not think big and aim high? And I'll leave it at that.